another insightful episode of MedSynapse podcast series. I'm your host, Hetvi Shah, and today we are marking World Dementia Day, a day that shines a spotlight on a condition affecting over 55 million people globally. Experts predict that by 2030, this number will skyrocket to 78 million approximately. Dementia does not just impact memory, it reshapes entire lives, making today's conversation on palliative care a lot more vital. Understand the role of palliative care plays in dementia management better. We are joined by Dr. Mohamed Nidhal, a neurointensivist with a special interest in neurorehabilitation and neuropalliative care. So, Dr. Nidhal, thank you for being with us today and on such an important occasion.
Yeah, pleasure is mine. Thank you.
So, now let's dive right into it. To start, how do you define the role of palliative care in the management of dementia? And why is it so crucial to incorporate palliative care principles early in the disease trajectory?
As I had briefly mentioned about the course of how the dementia goes, it does not only affect the patient per se, it affects the whole family, the caretaker per se, the caretaker or the whole family. So, when you're going to talk about palliative care in the first place, it is a specialized approach to improve the quality of life for patients with any serious illness, including dementia in our case, through the management of symptoms, emotional support, as well as ensuring dignity of the patient. What I would like to emphasize right now is that palliative care is not end of life care. Palliative care begins well before or the patient is in the last stages of the disease. And when I'm going to talk about palliative care in management of dementia, the dementia, there are many types of dementias, and each dementia there is a specific characteristic or there are some specific symptoms what we have to manage. In patients with dementia, what is the principle of management when you're going to look through the lenses of palliative care physician? It is more about symptom management, the psychosocial support, an important concept called advanced care planning, and very importantly is that it is a holistic approach where you're going to assess the patients. You're going to assess the patient's physical, emotional, social, as well as the spiritual aspects of the patient care. And more importantly, that it is caregiver as well as family oriented. You're going to give support to the family as well as the caregiver who's taking care of the patient. And coming to a second question, why is it crucial to incorporate palliative care early in the disease trajectory? As I told you, the patient has the dementia. When a patient is affected with dementia, the course of the disease is very long, and it's very vital to incorporate all the symptom management holistic approach as I mentioned prior early in the stages of the disease itself, so that we can have proactive symptom management and this advanced care planning as well as support for families, what they can expect, how to go about, and all those stuff. And very importantly is that you can reduce our crisis interventions. That is, when the patient is nearing his, the end stages, there will be lots of other comorbids, other illnesses. The patient can have an infection, a lung infection, urinary tract infection, and so on. And, when you're going to expect or anticipate all these prior, it will reduce the number of ICU admissions or hospital admissions, by preventing all those stuff in the first place. And as I had told priorly, it is very important to ensure the quality of life and the dignity of the patient, because those dementia usually sets in about 65 years, 75 years in the age when they are that old. And they must have had a very, dignified life by the time. And when you're going to, when the patient is going to have a dementia, they're going to lose their cognitive capacity. They are, they're not going to be able to walk. All your activities of daily living is going to be supported by someone. They'll feel very, depressed, and it's very common for them to have a psychiatric, a psychological effect on that. So, you must be very careful that people who have lived well, they should, pass well. That is a very important concept what we have to understand through today's webinar.
actually emphasizes why palliative care should be, integrated from the beginning, as you mentioned. So,
Sure.
caregivers play a significant role in the life of dementia patients. So, how can healthcare professionals better support caregivers in managing the complex needs of dementia patients who is receiving palliative care?
So, as we had mentioned prior, the caregivers or the family is the primary support of a patient with dementia or any serious illness when you're going to talk in that sense. The most important thing is that many of these caregivers or these families won't be, adjusted, or they won't be knowing what is dementia, or, how to go about with the patient with dementia. So in my when you're going to ask me this question, I feel that education and training of the caregivers and the family about what is dementia, what you're going to expect from this disease, how it's going to progress, what are the hiccups you're going to face in between. All those things should be, made very clear to the caregivers as well as the family when you're going to talk about the disease understanding. And the second point, what I would emphasize is how to manage some symptoms, common symptoms, which can be easily managed by the caregivers. When the patient is getting agitated, or when the patient is in pain, or the patient is having difficulty in swallowing, eating. When you're going to teach the patient, or the patient caregivers or the patient family how to go about with common symptom management. You don't need a expert physician or someone to, address all these issues. When you're going to teach the family or the caregiver about these common symptom management, it will be very useful for them. And next thing, what I would like to emphasize is communication techniques. Dementia patients, it will be very difficult to communicate, especially in the last stages. It would be better if the caregivers or the family has their own way, or they cope up with the communication technique what the patient is trying to tell the family from their sides. Next, how I would put the question forward is giving emotional psychological support to the caregivers from our side. We can arrange counseling sessions, we can have stress management sessions, because there will be lots of questions going on within them. They'll be thinking, am I doing enough for my father or mother or whoever it is. So emotional psychological support in the form of counseling sessions would be very beneficial for the patient. And next is coordination of care. When you're going to talk about palliative care, it is not just the physician and the patient. It's going to involve a very important person, that's the caregiver. So when you're going to involve the patient treatment along, when the three of us, the patient as well as the caregiver and the doctor who's taking care of the patient, the coordination of care will be very easy, and the case management will be very, the management of the patient will be very smooth. And also we can have regular check-ins, not very regularly, not very frequently, maybe, monthly once or bi-weekly or fortnightly once, we can have something like that. And very important is, accessibility. The physician or the hospital which is taking care, or the nursing home which is taking care, should be accessible over phone, or in case you need support, they can come over and, take care of, take care of the patient from their side. And a very important topic what I would like to emphasize is advanced care planning. So usually in patients with dementia, they would lose their cognitive ability early on in their disease itself, but they would be living very well. So what do you mean by advanced care planning is, you're going to plan in advance about how the disease is going to progress, and how the patient would like to cope up with those. That is, you can broadly take it into three aspects. That is, if the patient wants to prolong his life by whatever means it is, or the patient can either go with only comfort care, that is more of end of life care whenever the patient is in the end stages, or something in between. For example, the patient can tell, you can give me minimal, as less as medicines you can, but whenever I'm needing an ICU admission, I do not need an intubation or a resuscitation taking on me. So you need to it's very easily said, but when you're going to talk this to a patient, it's very difficult. So advanced care planning, whenever the patient is having the capacity to take decisions for himself, you should bring on these advanced care planning and document it, or you could at least get a proxy, some caregiver who is like a proxy for him, or a power of attorney for him, to decide whenever the demented patient is having loss of cognitive capacity, to take decisions on his behalf. So these topics are very important. And besides that, if at all the patient is being taken care at home, you can suggest some home modifications, as well as financial and legal resources. Taking care of dementia patients is going to be a very big financial stress on the patient caretakers as well. And when you're going to talk about strategies or resources for patient caregiver support, number one, what I would suggest is online groups or in-person sessions to support what they're going through and to have a better conversation. You can have educational resources and workshops, seminars like what you're conducting right now, what they can expect, and so on. We can refer some books and all. And an important topic is respite care. Whenever the caretaker is, you can always suggest a home care nurse, to support the caretaker or the family to, take care of the patient much better. I mean, to take care of the patient when they are not there, and so on. And you can always, bring the patient to a palliative care center or a hospital, where, depending on how the patient wants to be treated. You can take them to the hospital. There are many national organizations, NGOs, who are taking care of such patients. There are some local services. It depends on state to state, district to state, district, and all. And as well, you can always have professional counseling sessions with palliative care experts, and so on. So I think these are all the things which I would suggest for a patient for the patient caregiver to better understand how they can manage their family member who is suffering from dementia.
Insightful strategies, I think. Now, I think one challenge you encounter often is managing pain in dementia patients who might have difficulty communicating their needs. So, for that, what advanced techniques or approaches do you utilize to assess and manage complex pain syndrome in non-verbal or severely impaired patients?
Yeah, very good question. So usually, we use a sparse scale to prognosticate dementia patients. Usually when you're going to the higher grades, that is maybe around more than, fast scale 5, 6, and so on. These patients, they usually lose the ability to talk, or they are like, they have very minimal interactive, they interact very low, very less. So in these patients, the communication barrier is definitely there, and they won't be able to tell that they are in pain or they are having this issue, that issue, and all that. So, like when you're going to talk only about complex pain management in a severely dementia patient, it is very important to accurately assess the pain. As important as it is to find out where the pain is from, we have to first identify that the patient is in pain in the first place. So, how do we find out pain? There are lots of scoring systems. For example, the one commonly used is PAIN-AD, pain assessment in advanced dementia scale, which evaluates pain based on behaviors and like facial expressions, body movements, the changes in social interactions, vocalizations, and so on. We can always apply this to find out if the patient is in pain or not. Besides that, we can always have non-verbal cues, like when normally functioning people like you and me, when you are in severe pain, we tend to have some facial expressions and body language changes. We can use the same principles on patients with dementia as well. And very important, a very important thing what we cannot miss out is proxy reporting. That is, the patient caregiver understands the patient so well that, like even a small change in their behavior, the proxy or the caregiver is able to pick up, and they are able to report it to the physician, who can better understand that the patient is having some issue going on with him. So the proxy reporting that it is not just important to examine the patient and find out where the issue is coming from. It is also very important to get information from the caregiver, like how you treat a child, a newborn. How you collect information from the mother or the father. You have to take information from the proxy, the caregiver, to understand what is better happening with the patient. And when you're going to talk about pain management, if at all the issue is something which is not correctable, there is some abscess or there is some bed sore or something like that, which is manageable. You're going to find out the patient's having some complex pain syndrome. Could be because of many reasons. Usually, what we would do is, we start them on a normal NSAID only, maybe a paracetamol, or if at all the the patient's not improving that, we obviously go on with, higher analgesic doses, like maybe an opioid or a combined drug. We usually go on with this, especially if the patient is in a controlled setup, maybe in a palliative care unit or in a hospital or an ICU, wherever. A very important topic, a very important thing what I have to mention now is, dementia patients are very sensitive to all these patients and they very easily go in for respiratory depressions, especially if you're going to use opioid. So titration of medicine and usage of adjunct medicines is very important when you're going to talk about pharmacological management of pain management. And as we can always use non-pharmacological management, which is the first line. You can always talk to the patient or talk to the patient attenders about common things, repositioning the patient to a position where the patient is very comfortable. You can always use, an air bed or an alpha bed, what we call it. And we can always give environmental modification. We can take the patient out for a walk, or if the patient's bedridden, we can take the patient with the bed outside, provided the patient is stable enough. And we can also have these cognitive behavioral therapies and sensory therapies where, music therapy, aromatherapy, giving the patient some, ice chips or flavored ice chips to, just cheer up the patient more. And very importantly, regular reevaluation. Maybe if the patient is in a palliative care unit or is in the hospital or is at home, it's very important for, someone trained in management of pain go and assess the patient, monitor them continuously so that we do not miss out something more dangerous, what is going on with the patient. And we should also have the, role of artificial intelligence and wearable technologies in these scenarios. We can always have these wearable technologies, as simple as a smartwatch. When the patient is in pain, the heart rate goes up. We can pick up something as small as that, when you're going to monitor the wearable devices. And we can also use, artificial intelligence. Something what we can do is we can always take out the behavioral analysis and the physiological data to find out, if the patient is in this position, the heart rate and the behavioral pattern is changing. So you can always avoid that position. Maybe that position is causing pain to the patient. The patient is having, stiff muscles and the patient is in a fixed flexion deformity. The patient's not able to be held in that position for a long time. We can always use these data to, modify or alter our pain management strategies.
Thank you for highlighting that. Now, another critical aspect that I'd like to touch upon is how palliative care strategies might differ across various types of dementia, such as Alzheimer's or Impaired dementia. So, could you share some insights on how precision medicine principles are being applied in palliative care for these subtypes, especially?
Okay, so we are only, as you asked, these brain atrophy dementias, the Alzheimer's, Lewy body dementia, frontotemporal, and there are lots of other types of dementias, if you're going to refer in neurology textbooks. When you're going to talk about these atrophy types of dementias, the usual FTD, Alzheimer's, and the Lewy body, each subtype of these atrophy dementias have a particular characteristic. If you're going to talk about FTD, for frontotemporal dementias, they usually have profound personality changes. They have disinhibition, they have socially inappropriate behavior, or they are on the other end of the spectrum where they go for apathy or all those stuff. They also have speech difficulties, speech, word finding issues, or they have some types of aphasias, non-fluent aphasias, and so on. A very important thing is memory is preserved in the early stages, and it is affected only in the late stages of temporal dementias. And motor symptoms are kind of rare in these frontotemporal dementias. So when you're going to talk about frontotemporal dementias, it is morely about the personality and the behavioral changes. So when you're going to talk about Alzheimer's dementia, it is, as we all know, it's more about progressive loss of memory, and the cognition is gradually declined. And there is apathy, depression, irritability, and wandering. That is, the patient loses track of the route and they go from the market to their home, they go somewhere else. And the speech is also gradually worsened. But the motor symptoms are preserved in the early stages, and it is usually gone in the late stages only. And hallucinations are very rare in the early stages, and it keeps on increasing as the disease progresses. And when you're going to talk about Lewy body dementia, it is more about fluctuating cognition. The attention and alertness vary very dramatically. And hallucinations is very common in Lewy body dementia. And very important thing is these patients have Parkinson-like features. They have bradykinesia, tremors, rigidity, and motor symptoms are very early in the disease onset itself. And very importantly, they have sleep behavioral disorders. They, when they're sleeping itself, they feel that something is happening and they act out very violently in their sleep itself. So when you're going to talk about these types of dementias, we cannot, treat everything in the same manner. The importance of tailored care, I would like to emphasize the importance of tailored care. So how do you, when you're going to talk about palliative care strategies for each type of atrophy dementias, when you're going to talk about Alzheimer's, it is morely concentrated on memory and cognition as well as behavioral symptoms. And the importance of advanced care planning is very important, because the patient loses the cognitive ability very early on in the disease. So maybe when you're going to pick up the mild cognitive impairment itself, when you're going to talk about MCI, mild, moderate, and all those things, when you're going to see the MCI pattern, mild cognitive impairment itself, I think we have to bring out the topic of advanced care planning. We have to talk about how would you like to be treated when the disease is severe, or setting up a proxy and all that. I'm just touching upon all these topics because this advanced care planning itself takes 1 hour session, I guess. And as well, caregiver support, educating them like how the disease is going to progress, what are hiccups they can face, what all issues they're going to face, when they can approach us, when they can manage symptoms on their own, and on so far and so on. When you're going to talk about palliative care strategies in Lewy body dementia, it is morely about the cognition, the fluctuating cognition, the Parkinson-like symptoms seen, the rigidity, tremors, bradykinesia, and those things you have to address, and the visual hallucinations also. And a very important thing is we cannot use antipsychotics in patients with Lewy body dementia because it aggravates the disease, the symptoms very much, and we cannot manage those symptoms also. And we have to the care management itself is going to be very dynamic. When the patient is having a violent episode, we have to manage the violent symptoms in one way, and the patient is going to the other spectrum. When the patient is very mute or apathetic, we have to manage those symptoms in some way. So the care plan is going to be very dynamic. And when we're going to talk about palliative care strategies in frontotemporal dementia, it is mainly about the speech disturbance, the cognitive decline, as well as the behavioral variance. And we would also involve the caregiver as much as possible. And when you're going to talk about applying precision medicine in patients with dementia and palliative care. As we all know, the pharmacogenomics is coming up in dementia, There are lots of the biomarkers which are coming up, and individualized care plans for each patient. We can assess how the patient is, what type of the dementia the patient suffering from. We can very well assess how the patient is going to worsen, or how he is going to come around. Multidisciplinary approaches. We can always involve neurophysicians, psychiatrists, counselors, palliative care physicians, and so on. And as we had already mentioned, the use of wearables and how to monitoring those data from the wearables. We can use all that, and we can manage the patient, as a whole, with a holistic approach.
Okay, so I think precision medicine is actually more for, like, as you mentioned, that it should be tailored according to the patient's
Yes, definitely.
So now another issue often faced in dementia is the complex medication regimens that patients are on. So how do you approach the complex issues of polypharmacy in palliative care dementia? And especially what criteria do you use for prescribing these heavy doses?
Yeah, very good question. Dementia usually affects the elderly patients, usually. And in elderly patients, there are always going to be many, comorbids. The patient will be having diabetes, hypertension, coronary artery disease, as well as these medicines for dementia. The patient can have liver failure, renal failure, you name it, the patient might have it. So the patient will be on some 20, 25, 30, so many drugs. And we'll have to, there are lots of cross interactions and all in this stuff. So it's very important to avoid polypharmacy in the first place, because there are lots of risk associated with polypharmacy than the benefit. So how do we approach polypharmacy in palliative care in a patient with dementia? So first, we must, foremost, we must see how the patient wants to be treated in the first place. If the patient wants to live throughout with whatever intervention, whatever treatment we can offer, totally different scenario that is there. So in general, if you're going to talk about polypharmacy in palliative care, it is about initial assessment of the patient. You should see all the medicines, what the medicines have been given, what the patient has been taking right now, what is the patient stopped, was the patient having some issues with the medicine, and all that. Next thing what we would do is risk-benefit analysis of all the medicines. Is the patient going to benefit from these medicines? Is these medicines going to benefit the patient, or is it going to increase the life expectancy, or is it going to reduce the disease stage or something like that? And all these things should be assessed for these patients. And what criteria we usually use is the Beers criteria, as we all know, for de-escalating medicines. And in general, what we can use is all the medicines which are of high risk of harm or which lack benefit. We can definitely stop those medicines. And we can definitely discontinue all the non-essential medicines, because such as, the medicines which can cause sedation or which can cause increased falls or can, worsen the cognitive impairment. As you're talking in patients with dementia, these things should be always kept in mind. And we can always prescribe patients with long-term benefits, such as patients with statins or some antihypertensives, because these are not proven very much beneficial in advanced dementia. So always debatable. But if you're going to ask my insight, I think I would stop patients which are going to be a long-term benefit, because the importance of sticking to the regimen is always missed by these patients. So if you're going to give lots of medicines which are not going to have fruitful, it's not going to bear fruit, it's not going to be fruitful to the patient in the short term, I don't think the patient is going to take the medicines in the first place. So you keep as minimal medicines required, and you just give the fixed regimen. Morning these 6 medicines, afternoon these 4 medicines, night these 8 medicines. That's it. You take it and you're done. If you're going to keep on increasing the number of medicines you're going to add, which especially the medicines which are going to increase, which are going to bear fruit in long term, I think we can always come down on those medicines. And we can always, uh, classify the medicines according to symptom control as well as disease modifying. So I would always go with the medicines which are required for symptom control than for the disease modification. And as I told, we have to regularly reassess the patients, to see if the patient has worsened with, by stopping some medicine, especially statins, or, going, if the patient's on 5 antihypertensives, if you're going to stop 1 or 2 antihypertensives, we have to see if the patient's BP is still maintained or is it like going short up. So we have to again reintroduce these medicines and so on. So what I was thinking was, you have to always continue the essential medicines, patients, the medicines which have control for anxiety, pain managing medicines, and especially, diabetes or bronchodilators. These all medicines should not be stopped whatsoever. Yeah, that's it.
That is actually very true that some medications cannot be stopped, but then
Yeah.
certain unnecessary we can actually stop further burden on the patient.
Yes, yes.
And lastly, I'd like to touch on a very delicate yet essential aspect of palliative care, which is discussing prognosis and care options with families. So, what specific communication strategies do you find most effective in discussing these sensitive topics with the families?
Yeah. So, communication strategies in when you're going to deal with the patient with dementia. So this is not only going to involve the caretaker, but it's going to, you're going to talk to the dementia patient as well. If you're going to ask my experience, it's the toughest communication you're going to have in a clinical practice. It is very easy to deliver a good news, or the patient is very sick and you're going to talk to the attenders. That's also a different, communication skill in total. But when you're going to talk to the patient who is slowly losing his life, slowly losing the ability, is slowly losing himself, it is very difficult. And when you're going to talk to a patient with any dementia, and you're going to say that maybe from 6 months on from now, or 2 years from now, you're going to be bedridden. You will not be able to eat on your own. You'll not be able to take decisions on your own. I feel that's the most difficult communication anyone can have with any patient. It is as uncomfortable for the patient. It is as uncomfortable for the doctors also, or the physician who's talking. So I feel that, as you said, it's a very delicate topic. So we should have as clear communication skills, strategies when you're going to talk with such patients. So number one is creating a supportive environment when you're going to talk to a patient. We should have a very private, comfortable setup. It should probably be in your office, or if at all the patients in the palliative care setup, maybe in your office, or wherever there's enough privacy. And I would like to emphasize the importance of non-verbal communication. You should not keep your arms crossed. You should be more open and all that. And next is you should have a very good rapport. The trusting relationship between the caretaker, physician, as well as the patient is very important. And a very important thing is we should be consistent and transparent. We are not gods to decide, or to prognosticate or know what is going to happen to the patient, because when you're going to see a dementia patient, especially the end stage, the patient seems like he's going to be dying in a few days, but he'll be in that stage for almost a year, or 2 years, or 5 years. So the patient attenders or the caregiver, they'll come and ask us like, sir, he's like this, what do we do? There is, these are very difficult topics to touch upon, but these are all how it comes to you. So, you should be very consistent with what you're saying. You should not say that, he's going to die in so and so time. You should be consistent with what you're saying, and you should be very transparent, because we don't know what's happening with the patient, like how the patient also doesn't know. And we are not gods to, say what is happening, what is going to happen in the next few hours, years, or months, or whatever. And we should also tailor the conversation to very important, very gracefully. We should assess how much the patient or the patient attenders or the caregivers know, how much they're able to understand what you're telling, and all those stuff is very important. And you should also be very, sensitive. You should also be sensitive to the cultures. You should respect their cultural beliefs. From whatever background they are, we should also, we should respect all the religious beliefs also. Because, I believe that there are some religious beliefs who do not who do not accept very aggressive management in, when the patient is going to die and all that. So we should always, you should always respect all those cultural beliefs. And when you're going to deliver the information that this is the issue going on, I believe that you should always avoid medical jargons. You should avoid the use of medical terminologies as low as possible. You should always use it as a simple layman talk. And there are lots of Breaking Bad news protocols, the spikes, the past, all that. We can always look on that, and we can talk to the patient, and we have to assess the situation. It's very easily said. We should always assess the situation, and you should respond to it adequately. You should have clear explanations. We should clarify what you mean by palliative care. You should encourage questions and answer them in a very dignified manner. You should, assess. I mean, you should, respect the spiritual belief. Their emotional condition. All that we should be very wary of, and we should assess all that. And when you're going to talk about emotional support, we have to recognize their emotional response and acknowledge it adequately, and you're going to also offer resources. You can always refer them to a counselor or support group and all that. And you can always have smaller communication. You can give the information in bits and pieces depending on how much of the patient wants to know. So if the patient is ready to accept everything in a single go and decide on what he wants to go about in the forthcoming years, you can always give the information like that, provided the patient is ready to accept, or else you can always give it in small bite sizes, so that when in the follow-ups you can always pick up from where you dropped off in the last last counseling. And you can, if at all the physician or the counselor feels that the patient is going to lose his decision capacity, the decision-making capacity early on, we can always, we can always introduce the topic of advanced care planning in the early stages itself. And as I had already told, the team coordination with nurses, the social workers, sometimes spiritual care providers, counselors, and as well as the physicians, all should work in and around the patient as well as the caregivers. I think this is how we can go around.
Yes, actually, I think to concise it, open, honest, and compassionate communication is very effective.
Yes.
So before we wrap up, one last question would be, since today is World Dementia Day, I'd like to ask, what role do awareness days like this play in improving dementia care globally?
So that was a very good question. I think in the forthcoming years, like you had already, started off with the introduction, the elderly age group, the geriatric age group is always going to increase. So, and the subpopulation of patients who are going to be affected with dementia is always going to be on the higher end only. It's going to keep on rising. So when we're conducting such webinars or some awareness programs like these, it always helps the physicians as well as anyone who's watching this to know what is dementia, to find out, to seek help if at all the patient is having some dementia, like some symptoms related to dementia, and picking it up early, so that you can at least prolong the disease, and maybe to introduce the role of palliative care before, in the early stages itself, rather than talking about it when the patient is in the end of all the dementia symptoms. So I feel webinars such as this is very important to provide information, as well as how to go about when we are going to deal with some complex issues. I feel it's very important to have webinars such as this thing, and I believe that MedSynapse is doing a very good job in doing webinars such as these.
Thank you for those kind words, Doctor. And now, as we wrap up today's session, I would like to thank you so much for sharing your expertise with us today. And let me tell you that your insights on palliative care for dementia have been invaluable to us.
Okay, thank you, thank you.
And to our listeners, thank you for joining in. And let's use World Dementia Day as a reminder to support those living with dementia and their families as well. And remember, if you're a healthcare professional who is eager to delve deeper into medical topics or have questions, do not hesitate to join us on the MedSynapse platform. MedSynapse platform is not just a resource, it's a dynamic space where you can connect with your medical peers, participate in meaningful discussions, and contribute to the ongoing evolution of healthcare. So until next time, stay aware and take care of yourself.